Welcome to my discussion on overhydration, also known as fluid volume overload or FVO. Fluid volume overload is an excessive accumulation of fluid in the intravascular or interstitial compartments. It disrupts fluid homeostasis and potentially threatens organ function. Okay. Risk factors. Excessive fluid administration. So those IV fluids, those blood products, that's why we're constantly monitoring our patients. Heart failure. If your patient is in heart failure, they're going to have decreased cardiac output, which is going to have a decrease of renal retention of sodium and water. An increased renal retention of sodium and water. If they have renal failure, it's going to impair their excretion, again, of sodium and water. If they have liver cirrhosis, they could have hypoalbuminemia or portal vein hypertension. They may have syndrome of inappropriate antidiuretic hormone, which is SIADH, which causes them to retain water and sodium. If they are on corticosteroid therapy, corticosteroids, remember, increase fluid retention. They may have a high sodium diet, which again, more sodium and water love one another. So if you're taking in a lot of sodium, you're also retaining a lot of water. And then, of course, stress responses, the release of aldosterone and antidiuretic hormone. So expected clinical manifestations, I'm going to go through by body system. I think it'll make it a little bit easier to understand. So cardiovascular, we're going to see increased blood pressure, bounding pulses. We are going to see JVD or jugular vein distension. And we may even hear an S3 gallop, which is an early sign of FVO. Respiratory, we're going to have an increased respiratory rate, dyspnea, orthopnea, crackles or rales in the lung bases, and your patient may have a cough with pink, frothy sputum. That's super important, guys. Pink, frothy sputum, okay? Neurologically, altered mental status due to the cerebral edema. This is in the most severe of cases. But generally speaking, headache, visual disturbances. They may feel a little nauseous. GI and other weight gain, ascites, if it's secondary to that, liver cirrhosis. And then they may also have edema, which is peripheral or generalized. It may be sacral in your bedbound patients, but it's going to be pitting. Okay, they're going to have some pitting edema. It may not start off as pitting. They may just start off as general edema and then progress to pitting edema. Expected lab findings, they're hemodiluted. So think opposite of your dehydration, where with hypovolemia, everything was increased. This is hypervolemia. So all of your lab values are decreased hematocrit, decreased sodium, decreased BUN, decreased creatinine, decreased serum osmolality. It's just they're soaked and they are diluting everything. Okay, complications. These are the two big ones: congestive heart failure, pulmonary edema. Okay. Congestive heart failure with excess volume, it overwhelms the cardiac workload. You can have left-sided failure, which is going to result in pulmonary congestion and decreased tissue perfusion. You could have right-sided failure, which is more systemic congestion, hepatomegaly, ascites. Okay, so think of the patho-wellness. If you're increasing preload, your ventricles are overstretching. When your ventricles overstretch, they can't contract as well as they normally would, so they have reduced contractility, which has worsened fluid retention. It's a horrible vicious cycle. It just it feeds on itself. Okay, with pulmonary edema, this can be by itself, or it can be related to the congestive heart failure, the left-sided heart failure. Fluid accumulates in the alveolar spaces, which impairs gas exchange, which is why they have trouble breathing. And pulmonary edema, if left untreated, can progress rapidly and become a life-threatening concern. Clinical signs suggesting either CHF, congestive heart failure, or pulmonary edema. Worsening dyspnea, especially while they're resting. That pink frothy sputum, okay, that's classic for pulmonary edema. Severe crackles throughout their lung fields, orthopnea. So basically when they lay down, they have a really hard time breathing, so we want to sit them up, and it's going to be increasing. We're going to be sitting them up more and more and more, higher and higher. Profound hypoxia, that's going to be a low SpO2 despite providing them with O2 exogenously. Okay, so you're going to put that mask on them, you're going to put it at 2 liters, it's not really going to do a lot. You're going to have to get orders to increase the O2. It's still not going to do a lot, okay? And then, of course, your patient's going to be anxious and agitated due to the fact that they are low on O2. They are literally gasping for air, okay? Now, nursing assessment. We want to do daily weights, okay? This is the most sensitive indicator of fluid balance. A weight gain or loss of 1 kilogram in 24 hours is the equivalent of 1 liter of fluid. That you must know. 1 kilogram of weight gain or loss is equivalent to 1 liter of water. Okay, so that's why we're doing daily weights. This is also why we're doing accurate intake and output records. We are going to auscultate lungs for crackles, diminished breath sounds, rales. We are going to be checking peripheral and sacral areas for edema. We are going to be assessing the jugular vein for distension. Vital signs, we are going to note hypertension, tachypnea, hypoxia. Neurological status changes, if they suddenly, if they're talking to you and everything's fine, and then you come back to do an assessment 4 hours later and suddenly they're confused, they don't know who they are, where they are, or they're just speaking nonsense, okay? Those are neurological changes. Lab trend evaluations, so this is where monitoring their lab values is going to come into play. And then, of course, early signs of decreasing oxygenation. I do want to make a note that cyanosis of the lips is a late sign. It is a late sign. If your patient has cyanotic lips, you have missed several signs leading up to this, okay? Key nursing interventions. Restrict fluids as ordered, okay? Restrict sodium intake. Administer diuretics as prescribed. You want to elevate the head of bed. If your patient is having difficulty breathing when they're lying down, we want to increase the head of bed, okay? This improves their breathing. We're going to monitor their respiratory status closely. We are going to communicate significant weight changes to the provider, okay? Significant weight changes, remember, is anything more than a kilogram, 2.2 pounds, okay? That's in a day, 2.2 pounds in a day. That's a lot of fluid loss, okay? And then, of course, we're going to educate the patient on daily weights and fluid restrictions. Why are we doing these things? Because, like I said, a kilogram of weight loss is equivalent to a liter of fluid. And although we want them to have a decrease in fluid, we don't want it to be that rapid. That is an extreme amount for one day, okay? So, key takeaway, fluid volume overload is not merely excessive water. It's a physiologic burden with significant cardiac and pulmonary consequences. Early recognition and intervention are critical to prevent complications such as heart failure and pulmonary edema. I hope you enjoyed this presentation.